Before I forget. There we go. Perfect. All right. So y'all don't have any questions for me? Well, let's do a little Jeopardy and we'll see what y'all know. When I go back and forth between Collaborate and Skype, I have to remember, okay, what are the functions on this one versus Collaborate? As far as where you share and all. See if I do it. Okay. So let's see. So I'll just go through because on this one it makes it where I can't go back and forth looking at your comments. They'll just pop on the screen. So I'll just go through and we'll talk about the answers and we'll see how y'all do. So let's start with postpartum care for 100. Can y'all see the screen? First off, I want to make sure y'all can see it. Do y'all see exam 2, round 1?
I only see a black screen.
Shoot, well that won't work. Hold on a sec. Let's try it this way. Let me flip. Okay, now what do y'all see? Do y'all see it now? Or is it still just a black screen?
Yes, we see it.
Yay! Perfect. All right. So let's start with 100. So postpartum care for 100. So expected location and quality of the uterine fundus right after birth. Where would you see it and how should it feel? Yes.
Firm and at the midline?
Very good. Firm and at the midline. That's perfect. So that is what we would expect to see. Midline at the level of the umbilicus or immediately after birth. A lot of times it's 1 centimeter above the umbilicus. So if it's boggy and it's deviated to the side, we're looking at bladder. So the big differentiating characteristic of that is that deviation. So if you have a boggy uterus but it's midline, you're going to start thinking fundal massage, that is uterine atony. But if it's pushed to the side, either way, doesn't matter if it's right or left, think bladder.
So the fundus that's boggy, that's in the center, that's where we do the fundal massage?
Yes, ma'am.
Okay, because that would be like a sign of postpartum hemorrhage.
Correct.
Possibly.
Correct. Well, both of these can cause hemorrhage. Like a full bladder can cause hemorrhage as well. It's just with it being pushed to the side instead of it just being the tone of the muscle that's weak. This is where the bladder's pushing it up and out of the way so it's not able to contract. But they can both cause hemorrhage. Correct. Alrighty. 200. Components of the focused postpartum assessment. This is your bubble he. So if you remember your bubble he, that's your...
Breast.
Yeah, go ahead.
Breast, uterus, bladder, bowels, lochia, episiotomy, Homan sign, and emotion.
Good job. That's perfect. And I don't know if you were looking at the screen because I did pull it up on the screen. This is what we consider our focused assessment in our postpartum patients. So the things that we are paying attention to the most, because they are most likely to have complications related to that. So make sure you know what those pieces are of the postpartum assessment. Excellent job. All right, so edema and redness of the calf along with pain on dorsiflexion. What postpartum complication are we going to think with this? Yes, very good. DVT, perfect. So this is where we're going to think about a deep vein thrombosis or DVT, thromboembolism. So treatment for DVTs when they've already gotten a DVT. So best prevention is ambulation, active range of motion. But once they have a DVT, they're going to be on some kind of anticoagulant for several weeks. A lot of times it's going to be like Coumadin or Xarelto. Unless it's more severe, they might put them on heparin or something like that. They're going to be on some kind of level of bed rest. It could be partial bed rest. It could be complete bed rest. You don't want to massage the area because you can actually break off the clot and send it to their lungs. We don't want pillows behind the knees because of the way it angles the knee, as well as with that pillow behind it, it can impede circulation. And I already mentioned best prevention is your ambulation. Get them up and get them walking as quick as possible. So, release of oxytocin during breastfeeding causes what postpartum symptom to increase? What do they feel related to breastfeeding? It's not abnormal. Yes, contractions, very good, also known as afterpains. So they will experience those contraction feelings. What we call afterpains. It's good. The oxytocin is nature's way of stimulating those contractions so that the uterus contracts back down and stops the bleeding. So there are some other factors besides breastfeeding that can also increase these afterpains. The bigger the uterus has to grow, the more afterpains they're going to have. So if you've got that macrosomic baby, if you've got polyhydramnios, anything that makes the uterus stretch more can cause that largely stretched uterus. And then the more babies a woman has had, the more afterpains they usually have. So the more times they've had full-term pregnancy. So the multi-para mamas. So parameters that nurses should teach the postpartum patient to seek health care for. So what are some things if mama had when she got home that would be concerning that they should report? Yes, if they're having excessive bleeding, especially if their lochia goes backwards. So we talked about in class the normal progression where it starts with lochia rubra, then goes to lochia serosa, lochia alba. So if it progresses and then goes backwards, that can be a sign of bleeding. If they have any symptoms of infections, whether it be hematuria or dysuria with a urinary tract infection, if they're having breast pain, especially one side or the other, if they're having pelvic pain, that could be a sign of a endometritis. If they're having yes, that was the next one I was going to say, the sadness. If they're having feelings of sadness or depression, if they're having any kind of suicidal thoughts or homicidal thoughts, paranoia, hallucinations, things like that. If they're having difficulty breathing, shortness of breath, that could be a DVT. So we talked about the lochia changing back to red. Oh, and another thing is if the lochia has an odor to it that could indicate infection. If they continue to have those afterpains, so the afterpains are normal only for about 3 days. If they're continuing to have those cramping kind of pains more than 3 days, that could be indicative of either infection or retained placental fragments. Any kind of fever. We talked about the breast pain. the calf pain, difficulty breathing, if they're having abnormal signs related to a surgical incision, so whether it be the C-section, episiotomy, or if they had a laceration that was prepared, anything like that, if they're having like the redness and edema, discharge, not well approximated, things like that, that can be a sign of wound infection or wound complications. Alrighty. So, the defining parameter separating postpartum blues from postpartum depression. You mentioned it, Heather. We were talking about warning signs. Yes, so 10 days. 10 days is the big difference. It's time, and the time is 10 days. So up to 10 days, as long as it goes away by 10 days, it's considered postpartum blues. It's just part of the normal hormonal changes that occur in a postpartum patient. As long as it goes away within 10 days, it's fine. If they continue to have symptoms, or if their symptoms start more than 10 days after they've had their baby, that is postpartum depression, which requires treatment, oftentimes with medication and counseling, especially medication. So the primary nursing intervention in a postpartum patient with heavy vaginal bleeding, if you've got a lot of bleeding, what are you going to do first? Yes, bundle massage. So just bleeding by itself, especially if you don't know the source yet, we can do a fundal massage, and hopefully it will help those muscles contract and stop any excessive bleeding that they're having. Good job. All right, so cough, difficulty breathing, low-grade fever, hypoxia, petechia on the chest. What might all these, when you put them together, point to that we would be concerned about? It could be something that started in their leg and traveled. Yeah, it could be a PE, so it could have started as a DVT and then broke off, traveled to their lungs, and became a PE. So when you put all these symptoms together, cough, difficulty breathing, that's kind of hard to place. Even low-grade fever, do they have a pneumonia? Could it be that? But then when you start looking at the petechia, for example, oftentimes they'll have crackles with it. They might have a widening pulse pressure where their blood pressure gets wider as far as the gap between the systolic and diastolic. So those are some of the symptoms that you'll see with it once you start putting all that together. All right, bilateral breast tenderness, heaviness, firmness, and warmth may be a sign of what in the postpartum patient, if it's bilateral? Yes, this is more likely to be engorgement. So mastitis is usually going to be one breast or the other. I'm sure you can get bilateral mastitis, but it's going to be pretty uncommon. If they're having pain and fullness and heaviness in both breasts, you're going to start thinking engorgement. So teaching them things like emptying their breast frequently and fully. So actually, that's part of the next question. So how to treat it in a breastfeeding patient, emptying fully and frequently. Heat is what we would use for breastfeeding mamas. For bottle feeding mamas, we would use cold because that will help decrease that milk production, but we want to use heat if they're breastfeeding. It helps with the flow of the milk. Wearing a supportive bra at least during the day, if not all the time. Some women find it even helps even more so to wear it while sleeping. So in non-breastfeeding patients, I mentioned the cold. The cabbage leaves are good because they're not only are they cold, but they secrete an enzyme that helps decrease milk production. Also wearing a supportive bra for them. And unlike breastfeeding patients where you want to increase stimulation because it will increase production, you want to avoid stimulation in patients that are non-breastfeeding. So avoiding water hitting their chest, avoiding any kind of, like, even the rubbing of their shirt. That's where a bra can come in and be helpful as well. It prevents any kind of stimulation to the nipples and to the breasts, which can cause milk production. All right. The only parameter that would contraindicate continuing to breastfeed on the affected breast with mastitis. The one thing, if they have present, they can know they should not continue to provide that milk to the baby until the infection clears. Yes, very good. If they have an abscess, they should not continue. They should continue to empty their breast because they need to release that pressure. Because if they don't, it is just going to make it worse. But they should not give that to baby because in that case, you're providing milk that is tainted with pus oftentimes, versus if it's mastitis without an abscess, it's just infection of the tissue, so it's not where it's draining. Good job. All right, so newborn care. Switch it up a little bit. The optimal time after birth to obtain a newborn screening test. What is the best time? How long after birth? Yes, at least 24 hours. Very good. So really the best time is 2 to 3 days, but I mean, babies aren't even in the hospital that long. So they really should wait at least 24 hours. And the reason for this is because in order to test for metabolic diseases like your PKU, your galactosemia, maple syrup urine disease, all the ones that are metabolic based, in order for the test to be accurate, they have to take in whatever it is their body doesn't process. So if they haven't had enough protein, for example, for their body to build up those byproducts of having PKU and not digesting it properly, then the test is not going to have anything to detect. The test is detecting those byproducts that their body creates because they don't break it down properly. So if they haven't ingested enough to break down to cause a positive result, then the test will be inaccurate. So minimum of 24 hours after birth, and they've had a few feedings in their system, so that way those metabolic diseases can be accurate. So, and I just explained why. They need to ingest protein for PKU, protein for maple syrup urine disease, lactose for galactosemia, depending on whatever the metabolic problem is. So after briefly assessing the ABCs, so making sure they're breathing and their heart's beating, what is the first thing nurses do to the baby immediately afterwards? Okay, you're breathing, then what? Before we do that, before Apgar, before we put it on mom's chest, we're going to dry the baby off. So we've talked a little bit about cold stress, and we don't want babies to get chilled. So once we look at them and say, yep, you're breathing, and you're probably doing kind of the Apgar at the same time, we are going to dry them off really well, because just the fluid from the amniotic fluid and vaginal discharge and all that stuff, being on baby, it can chill them to the point of giving them cold stress. So we want to dry them off first so that they don't get any kind of cold effects from that. And then, of course, doing the Apgars as part of that, like you mentioned, putting baby to mom's chest, that kangaroo care, that is definitely a big part of it. Most hospitals now have what they call the golden hour, where other than initial what we have to, like getting Apgars and establishing airway, drying them off, all that good stuff, they leave the baby with mom for the first hour after birth. And the purpose of this is to establish that attachment, bonding. Kangaroo care is really good, where they do skin-to-skin contact, no covering on the baby except for a blanket over them, against mom's bare chest, or even dad. Dad can participate in skin to skin as well, and it helps stabilize vital signs. It helps with thermoregulation. It helps with so much, even physically. So highly recommended. And I already talked to you why, to prevent heat loss. So cold stress can cause, what two big problems do we focus on with hypothermia or cold stress? Yes, hypoglycemia and respiratory distress. Perfect. So that's what we're worried about. We're worried about them dropping their blood sugar, and we're worried about them having respiratory distress if they get too cold. So it's not just a comfort issue. It can cause medical complications. All right, so what medication is given to baby right after birth to prevent eye infections or neonatal conjunctivitis? Yes, very good. Erythromycin. So ophthalmic erythromycin, it's a gel that is put into the eyes pretty shortly after birth, usually within that hour time period, and it is just in case mom had any kind of infections like chlamydia or gonorrhea and was unaware. This will help prevent those infections from baby getting an eye infection, because it can cause blindness in the baby if they contract those and get an eye infection from it. Very good. Ophthalmic erythromycin. All right. A normal expectation in the head of a newborn related to passing through the birth canal, and it disappears in a few days. What is this called? There's a reshaping of the head. I know this one I don't think I talked about on the recording. So this is called molding. This is where, and you'll see babies that have had a vaginal birth, their head kind of comes a little bit to a point, or it looks like it's squeezed at the top. And this is as baby is passing through the birth canal. It's just where those cranial bones that are not, fixed are shifting a little bit to help baby fit through. It's normal. It's fine. You don't see this, of course, in C-section babies because they didn't have to pass through the birth canal. But the two things that are abnormal, now these two things normally go away on their own, but they're definitely something that they will watch. So when you have a collection of fluid under the scalp that crosses the suture line, so it looks more generalized across the head, this is called a caput succedium. So a caput succedium, when you think of crossing the suture lines, think a cap, like a cap that sits on the head like a hat. The caput succedium sits on the head like a cap. It fits over the head. It's more generalized. Versus the one that doesn't cross suture lines, it's more localized, is your cephalohematoma. So those are some of those differences that you'll see in the head of a baby.
Is the normal one the one that they consider like the cone head?
Yes, you'll hear a lot of people call it cone heads, especially in preterm babies. They often get a pretty significant cone head, but that's exactly what it is.
Okay.
Yes, ma'am. So what body system is affected with untreated high bilirubin levels? And it's not the liver. We always think of bilirubin with liver, but in this case, it's not the liver that the bilirubin affects. It's another body part that can have permanent complications if bilirubin levels are high and untreated. Not the kidneys, the brain. Very good. So the brain is what we worry about. This is something called kernicterus. We'll type it in the chat, kernicterus. So kernicterus is where you have high bilirubin levels and they go untreated. And what happens with bilirubin is it'll deposit on the brain tissue. And the brain does not like bilirubin. And that bilirubin causes permanent brain damage. So that's why they stay so focused on treating high bilirubin levels in babies, is because you can reverse the bilirubin and give them billy lights and different things to help bring down the bilirubin. But once they develop kernicterus, where it causes brain damage, you can't reverse that. You can't reverse the damage that's been done. So we're trying to prevent that. So if they're worried that that is what that's what happened later on, they can do things like vision and hearing tests. Those are usually the best indicators of detecting neurological impairment from kernicterus. Is hearing and vision studies. So we worry about, even though we associate bilirubin with liver, as far as what organ it's going to damage, if it stays high, that's going to be our brain, or baby's brain, I should say. Kernicterus. All right, increasing IV fluids and turning the mom on her side. What complication of anesthesia or epidurals can they get that we can do these things for? And this complication can happen even after they've already given birth. That's why we're talking about postpartum. Yes, hypertension, hypotension, not hypertension, hypotension, where they drop their blood pressure. They can have this even later on. The medications can cause it. Having the epidural in place can cause it, where they drop their blood pressure. So we can give mom extra fluid to bump up their blood pressure, and we can also turn her on her side, and that will hopefully alleviate the symptoms. All right, so priority nursing intervention in a baby with acrocyanosis. If they have blue hands and feet, what are we going to do? We are going to monitor. There's one other thing we're going to do. It's nothing concerning. Yes, we can do that. We can cover them both. Basically, yeah, swaddle them. We want to warm baby up. So that's the biggest thing. When they have acrocyanosis, where it's the hands and feet that turn blue, this is where the blood is being shunted away because they're cool. So we can either, like you said, Jalen, put that skin-to-skin contact with a cover over both mom and baby, swaddling them, like you said, Natalie, putting them under a baby warmer, like you said, Ureli. All of those are correct. Basically, we're looking for something that will cover or warm up baby. So it's just like, even as adults, if you get really cold, sometimes your skin can have that mottly look in your hands or your feet. Kind of the same thing. It's shunting that blood away from their hands and feet to warm their core. So we just need to warm them up. But nothing super extensive as far as interventions. It's not something that we're worried about, like hypoxia or something like that if it were central cyanosis. So nursing care parameters of an infant with spina bifida cystica. You'll also see the word of myelomeningocele, which is the other term for it. If they have not had surgery yet, what are we going to do for that baby to keep them safe until they go have surgery? So spina bifida cystica or myelomeningocele is where they have the pouch that's actually on the outside. So spina bifida occulta, which is where it's hidden, is where it's under the skin, but it's still covered. So there's not risk of infection and rupture like you see with spina bifida cystica. With myelomeningocele or cystica, yes, you want to lay them in a prone position. Exactly, you don't want to put pressure on the area. So we put them in prone positioning. They lay on their bellies so that they're not laying on their back. We'll put them in an incubator, one for infection prevention as well as thermoregulation, and we'll use warm, moist gauze and put that on the sac because we want to maintain integrity of the sac. We don't want that sac to rupture because that's all that is keeping the spinal cord from being exposed to the outside. So we want to maintain that integrity until they go to the OR, usually within a few days. It's not an emergent surgery. It's not something they rush them off to the OR immediately as soon as they're born, but it's kind of an urgent surgery. They'll do it within a few days usually, but until they do that, you want to protect the integrity of that sac, putting them in a prone position, monitoring for signs of infection, things like that. And then, like I mentioned, as far as infection control, they'll be in an incubator. They will definitely be on contact, droplet, all those kind of precautions to keep from them getting sick. That reverse isolation. All right, so retinopathy of prematurity. What causes retinopathy of prematurity? It's something we actually do as healthcare providers. What do we do to cause retinopathy of prematurity? Yes, very good. We give them too much oxygen. So most of the time we think of oxygen as a great thing. Just load patients up. But when we're talking about preterm babies, that can have some very negative effects. We have to be wary of how much oxygen we give these babies. This is one of the complications that can happen from that. If we give them too much oxygen and just load them up, it constricts those blood vessels that are supplying the retina with oxygen, and with it being constricted, or with blood flow, and when it is too constricted, it's not allowing for blood flow, and it causes the retina to die essentially. So they can become blind. So we in preterm babies are very careful about how much oxygen, keeping a very close eye on their oxygen saturations, and only giving them the amount of oxygen they need, not just loading them up. And a lot of times with preterm babies, we don't want their oxygen saturations to be 100%. If they're 100%, because they're getting additional supplementary oxygen, that's too much. So they may only want their sats to be 92, 93% because they're trying to give them only enough oxygen to support them without overloading them and giving them oxygen toxicity. So we can give them too much oxygen, which can actually create the problem. And then I already mentioned how it can be prevented, monitoring those oxygen saturation levels, and then only giving however much is needed to maintain oxygen saturations for viability, not to max them out. All right, the best way to most accurately determine that an infant belongs to a specific mother. So they both got armbands on. What information are they looking for when they're comparing armbands? Y'all might not know this because I know only a few of you. So yes, they don't actually use the name. So that's where this is different. Normally in most patient care areas, we ask name and date of birth, right? But with babies, they don't. They use a number. Usually it's a medical record number. So to make sure there's no potential for misunderstanding or just saying what it is and having the wrong baby placed with the wrong family, they actually, when they take baby into mom's room, they'll have the mother read off the medical record number that's on her band, and then they'll be checking baby's band at the same time to make sure those numbers match. So that's a little bit different than we're usually used to in other areas, because most areas they're actually comparing by name and date of birth, versus here we use medical record numbers to increase that accuracy, because we don't want babies going home with the wrong families. So comparing the security number, which is usually the medical record number. All right, which reflex is known as the startle reflex? What's the other name for the startle reflex? Yes, the Morrow, very good. So the Morrow, we can either do a hand clap or any kind of noise should make the baby startle. So they'll fan their arms out, fan their fingers out. You should see it bilaterally. So if you only see it on one side, that could be a sign that there's some kind of nerve damage or neurological damage. Or if they don't do it at all, it could be a sign of some kind of hearing impairment. So that helps us see those kind of functions. So the reflex where the toes fan when the foot is stroked, I know y'all know that one very well. That is the Babinski. So in children under 12 months, you expect to see the Babinski where their toes fan out. But in children that are over 12 months and adults, anybody older than that, you would not want to see this. If you saw a positive Babinski, that would be a sign that they have potentially neurological impairment, like head injuries is the big thing I think of when I think of Babinski. But it could be other things. It could be meningitis could cause it. It could be any kind of any significant event that causes increases in the pressure in the head. And then the reflex where the baby turns the head when the cheek is stroked. What's that one called? Yes, rooting. So when you rub baby's cheek, whichever side you rub their cheek on, they'll turn their head in that direction, and this helps them find food. So the purpose of this is, if you're thinking about breastfeeding, if their face rubs up against that breast, then that teaches them to turn their head towards that so they can find that food source. It's to help them find food sources, basically. Good job. All right, fever, cramping, increased lochia, or malodorous lochia. What postpartum complication are we going to be thinking about if those symptoms are what the patient is complaining of? Infection. What kind of infection? Infection of what? Yes, very good. So that's a uterine infection, aka endometritis. Screen, I'm going to switch. There it goes. Endometritis. So endometritis is that uterine infection. So the big thing that would make you think uterine as opposed to anything else would be the cramping and the lochia changes. Fever you can have with all kinds of infections, UTIs, mastitis, the endometritis, but the cramping and the lochia changes, that's going to make you think uterus. Could have pelvic pain as well. I know that's one we talked about in class was the pelvic pain. All right, the best method to increase breast comfort in a mom who's bottle feeding. What can we tell bottle feeding moms to do to help decrease engorgement and make them more comfortable? Yes, cabbage leaves, ice packs, supportive bra. We don't want them to express milk in a bottle feeding patient. Now, if this was a breastfeeding patient, absolutely, definitely. We want them to empty their breasts often and fully. But in a non-breastfeeding mom, we don't want them to have any kind of stimulation or emptying their breasts, because the more they empty their breasts and express milk, the more their body is going to produce. But the cold cabbage leaves, the ice packs, the supportive bra, and decreasing stimulation, those are all great measures for bottle feeding mamas so that they are not increasing production of milk, which is going to make the problem worse. Normal vital signs in a newborn. So what is a normal heart rate? Yes, normal heart rate 110 to 160. Respirations, very good, 30 to 60. What about blood pressure? Do y'all remember blood pressure? Yeah, So a little bit high on the systolic, so 60 to 80 over 40 to 60, a little bit low on the diastolic, but it's pretty low. It is, compared to what we're used to seeing in adults, it's significantly low. The first time I got pulled to the NICU when I worked in pediatrics and I was doing a blood pressure, I almost panicked when my baby's blood pressure was 70 over 40, and the nurse was like, "Oh no, it's fine." Which it was totally fine. Yes, temperature. So temperature really doesn't vary too much from adults. They might have a slightly higher temperature, like for a newborn, 99.8 is still considered normal. But overall temperature is not going to vary that much, as well as your pulse oximetry is not going to vary at all. That's still that 95 to 100%. As far as which parameters you should really focus on, in babies, we don't really do blood pressures too much. In fact, as far as routine blood pressures, they don't even do it in the newborn nursery. Now, when babies have to go to the NICU or like a special care nursery, things like that, they'll do blood pressures on them. But as far as standard routine of care in a normal, healthy newborn, they don't usually do blood pressures. Under the age of 3 years old, blood pressures are pretty inaccurate. So unless we have a physical need to get a blood pressure, we typically don't even worry about it. So heart rate and respiratory rate are the two big ones you should definitely know what the parameters are. Temperature is important, but again, temperature really doesn't vary from an adult. So if you know an adult temperature, you're good to go. There they are. Just like we talked about. All right, symptoms of postpartum psychosis. Besides the suicidal and homicidal ideations, what are some other symptoms of postpartum psychosis that may precede it?
Thoughts of hurting the baby?
Yep, those homicidal thoughts, absolutely. So sadness, they might have they'll have more symptoms of what we call psychosis. So symptoms like paranoia, hallucinations, some of the things. So I know y'all haven't talked about any kind of psych as far as digging into the deep psych symptoms, but when you talk about bipolar disorder in your Jerry psych class, the symptoms that y'all talk about related to mania. So the paranoia, psychosis, something called thoughts of grandeur, where they think very highly of themselves, basically, and where they think they're doing very grandiose things, where they have racing thoughts, those kind of things. Yes, Heather, that can be part of it as well. They think either baby would be better without them, or they start thinking baby would be better, like they're going to go put baby with Jesus, because that baby would be better off that way, instead of thinking of the process that it's harmful. So it is definitely a psychiatric psychosis. This isn't something that is going to, they're going to just work themselves out with it. And we associate this with bipolar disorder typically, and it's during that manic phase, because the hormonal changes in the postpartum period will send them into a depression, and then they'll whip around out of that depression into a manic phase, and that's when they start having the really concerning psychotic type symptoms. So they are going to need to be admitted and put on antipsychotic medications. So let's see how you do with math. So I mentioned in class today, which I'll mention with those of you who are in the evening class, that we do baby weights in grams. So let's see how you do figuring out a dosage calculation, and we're talking about a baby in grams. So we have an infant who weighs 4,800 grams, and they're ordered to receive 10 to 15 milligrams per kilogram per dose of acetaminophen. So what is the minimum dose the patient should receive in micrograms? So lots of conversions there. You got to convert your grams to milligrams, or grams to kilograms, your milligrams to micrograms. So let's see how you do. So I'll give y'all a second to work through that, and then we'll talk about it. So your first step when we're looking at this is to convert your baby's weight. So in this case, grams are actually pretty easy to go back from grams to kilograms because you're just going to move it over 3 spots. So for instance, just looking at this baby that weighs 4,800 grams, if we move it over 3 spots, this baby weighs 4.8 kilograms. So first thing we do is convert that weight to kilograms. So 4.8 kilograms. And in the question, it's asking us what is the minimum dose we would give. So we only need that 10 milligrams per kilogram per dose. If it asks us maximum dose, then we would go with the 15. So we take that 4.8 kilos, multiply by 10 milligrams, since we're only looking for the minimum dose. So that means this baby should get 48 milligrams of acetaminophen. Seems like such a low dose compared to what most of us are used to taking. But 48 milligrams would be a minimum appropriate dose for this baby for Tylenol. So we want to know, though, how many would they give in micrograms? Now, Tylenol is not given in micrograms. It is given in milligrams. But I just added an extra to this just to help with your conversions, because I know that's usually a big struggle for people is conversion. So if we take that 4,800 milligrams, there is 1,000 micrograms in 1 milligram. So when we multiply that by 1,000, that gives us 48,000 micrograms, if that were what we were looking for in micrograms. But Tylenol is given in milligrams. But that way you see the conversion. Very good. All right, any questions on any of those questions we just talked about? Anything you want me to elaborate on or go back?
Will we have the percentage of weight change on this exam?
Yes, ma'am. And I actually have a question on the next Jeopardy round, so let's go ahead and talk about that one. We'll do an example.
Ms. Martinez, are you posting these Jeopardies?
No, because I record them on the video, so they'll be the tutoring video will be recorded on YouTube. So you can go back. I'll have it up by tomorrow.
Okay.
Where'd it go? Oh, there it is. Alrighty. All right, let's see if it works. The first time this time. All right, can y'all see that? Or is it just a black screen?
It says it's loading.
Oh, okay.
See it?
Yay! First time. I love when that happens. So I'm actually going to go to Final Jeopardy first before we do the other questions. Since, Heather, you asked about the example with the newborn weight loss, let's go ahead and do that first. All right, so here's an example of what you might see. So when we're talking about normal newborn weight loss, newborns lose a percentage of weight after birth, up to 10%. So 5 to 10% is typical. You want them to gain that back within 10 days after birth. But we have to figure out what they actually lost. So when we're looking at figuring out normal newborn weight loss, we take their birth weight and subtract whatever the second weight is to get the number of grams they actually lost. Then we divide that by their initial weight, that birth weight, and that gives us a ratio. When we get that ratio number, then we multiply by 100 to give us a percent. So let's talk about this one. So a newborn is weighed at 3,752 grams at birth. So that is their birth weight. 3 days later, after their birth, the infant is weighed again, and now the infant weighs 3,497 grams. So based on those numbers, we need to figure out what is the percentage of weight loss for this baby. So our first step right here is where we're just subtracting the the secondary weight from the birth weight, and that tells us this baby lost 255 grams of weight. So 3 days after birth, they lost 255 grams of weight. So once we've determined how much weight they've lost in grams, we put that over their first weight or their birth weight. So we take the 255 grams, we divide by the 3,752 grams because that was their birth weight. And then because that gives us a decimal, that'll give us 0.068, we multiply by 100, which turns it into a percentage. So when we do the 255 divided by the 3,752 and then multiply by 100, it gives us 6.8% of the baby's birth weight that was lost. So is this normal? Yes, this is totally normal. That's within that 5 to 10% range. So that will help us determine baby's okay. Baby doesn't need any kind of extra supplementation or support as long as they end up gaining that weight back up to at least birth weight by 10 days after birth. Any questions on the weight loss? Any issues, any difficulties or issues with that? Okay. So let's talk about our other questions. All right, nutrition, everybody's favorite. The answer is not always leafy greens or chicken. So avoidance of phenylalanine and using lofenolac formula are important dietary needs in a patient with what metabolic disorder? Which one would we avoid phenylalanine with? Yes, very good. PKU or phenylketonuria. So with PKU, they have to avoid meats, dairy, and diet sodas because they all contain phenylalanine. Now, you can't completely avoid protein. You do need some protein just to survive, but they have a very low protein diet. So babies who have PKU or phenylketonuria cannot breastfeed because mom's diet would not be able to support what that baby needs. It would end up causing complications in the baby. So instead, they put baby on a specialty formula called lofenolac. And that's how it's spelled up here. So phenylketonuria is what, if they have that, they'll be put on this specialty formula called lofenolac, which is a very low protein type of formula. All right, teaching parameters for breastfeeding. I think this is very similar to what we talked about as far as comfort and things like that. So, but this is more so how to make sure baby is breastfeeding appropriately as opposed to like engorgement and comfort and things like that. So breastfeeding should take place 10 to 15 minutes per side. So a typical feeding for any baby should take 20 to 30 minutes. Even if they're bottle feeding, usually it should take about 20 to 30 minutes. And if we're feeding 10 to 15 minutes per side, breastfeeding, that is also 20 to 30 minutes. They should be feeding at least every 2 to 3 hours, so that and fully emptying their breasts. A lot of times, especially when they are first starting out breastfeeding, they will recommend that they pump after feeding to increase that production and making sure they're fully emptying their breasts even if baby stops eating. They should alternate which breast they start with. So if they start with the right breast this time, they should start with the left the next time. And the reason for this is because babies have a stronger suck with whatever breast they start with. So if you're always, say, starting on the right breast is going to produce far more milk than the left, causing inequalities, but it's also going to increase the risk of maternal nipple damage on that right side if you're not alternating. And also alternating positions. So in class we talked about different positions you can put baby in, like the cradle hold, the football hold, the sideline, using different positions that baby is in as much as the mother can tolerate it depending on what's going on with her. can also help because the mouth is going to be in a different position. It decreases that risk of breakdown. Babies should never, ever, ever have free water under the age of 6 months. And what I mean by free water is extra, just plain water by itself, or if the formula is being diluted more so than the manufacturer recommendation. And those are usually the two reasons you see babies getting extra water. They get all the fluid they need through either breast milk or formula, depending on what they're taking. They don't need extra fluids. The problem with free water is there's no electrolytes in it, and their kidneys cannot concentrate their urine the way we can as adults. So they will dump out all this water, and it will drop their electrolytes because they're flushing out electrolytes, and they can have seizures from the reduced sodium levels. So no free water if they're under 6 months. You want to make sure a baby has a good latch, that they are taking in the amount of breast tissue that they're supposed to. So they should have all the nipple in their mouth as well as most of the areola. And that is going to allow them to have enough tissue to suck so that they're actually pulling milk and not just essentially just damaging the nipple. And then one thing I didn't really talk about too much in class, I don't remember if I mentioned this on the recorded lecture, as far as how to remove baby from the breast. So if any of you have breastfed and baby just all of a sudden pulls off, is going to cause some damage to the tissue. So you don't want to just pull baby off when there's a suction applied using their pinky finger to kind of get in between in the crack of baby's mouth to loosen that suction so that you don't cause damage to the tissues. So this may be found in the newborn when the mom has maternal nipple damage. So if the mom has maternal nipple damage, there may be something in the baby's mouth that could have caused it. Not thrush. It's an anatomical thing. Something to do with their anatomy. The frenulum. So the frenulum, if they have a tight frenulum, or sometimes you'll hear it called a thick frenulum, so that piece under the tongue right there that holds the tongue to the base of the mouth, if it's very large, it doesn't allow the baby to open their mouth as well. That's all right. It doesn't allow them to open their mouth quite as well. So because of that, yes, that's what a lot of times you'll hear people call it, is they're tongue-tied. That's kind of the layman's term for it. And if they can't open their mouth wide enough, they're not taking enough breast tissue into their mouth, so again, causing problems with maternal nipple damage and all that. Yep, so they'll do a frenulectomy or frenectomy, and it's very simple. When they are a newborn like that, they literally just take a pair of sterile scissors and just clip it in the doctor's office. They did my daughter's at the pediatrician's office when she was 3 days old. No big deal, hardly even cried, because it's so small at that point, it really doesn't even bleed that much, and doesn't cause them significant adverse effects. Now, as children get older, if it's caught later and they need to do it later, it's a significant procedure that requires conscious sedation. Usually they have to go to like an oral surgeon or something like that. But it is, as a newborn, very easy to fix. All right, tight frenulum or thick frenulum, you'll hear it called, or like Ureli mentioned, it's you'll hear it called in layperson's terms that they're tongue-tied. Methods to determine adequate breast milk intake in the newborn. So how do we know if baby is getting enough? Yes, diapers. How many diapers? How many wet diapers should they have before, a day? 6 to 8. Very good. So we can weigh them before and after feedings, but it's not going to be unless you're in the hospital where you have a gram weighing scale, it will be harder to determine that. Now, in the hospital, especially if you're really worried about it, like in the special care nursery and things like that, definitely they can do that. So we want 6 to 8 wet diapers a day. There's also some factors you can see with baby. For example, if they are audibly swallowing, if they appear sleepy afterwards. I'm sure some of you have either seen this or heard the term that baby appears milk drunk, where they get very sleepy after breastfeeding. That has to do with their bellies being full. So if they are, the breasts feel softer after the feeding, so they were firm and now they're soft, indicating that the breasts have been emptied. And if baby is able to feed for, that should say 10 to 15 minutes per side, not per session, but if they're feeding 10 to 15 minutes each side, that gives an idea that they are feeding long enough that they are having adequate intake. But the number of wet diapers, 6 to 8 a day, is the best one. All right, expected additional calorie intake for a lactating mom. How many extra calories should a mom have per day if she is breastfeeding? Yes, very good. 500 extra calories. So breastfeeding moms often feel very hungry and still lose weight, but it's really only about the equivalent of 1 extra meal a day that they should be having. And that's all that is really needed. As far as additional fluids, how much extra fluids should they be drinking per day? Fluids are very important to breastfeeding. If mom is dehydrated, her body's not going to be producing breast milk. It takes tons of fluid to produce what seems like not that much breast milk. Yeah, so they should take about an extra liter or an extra 8 to 10 cups. So when you're talking about the average adult is supposed to drink 2 liters, about 3 liters or a little over 3 liters is what they recommend for a breastfeeding mom. So it's a significant, increase in fluids that they should be taking, because that you want them to be able to produce enough breast milk, and if they're dehydrated, that's the first thing their body is going to pull from. All right, because newborns cannot shiver to regulate their body temperature, if they're shivering or if they have jitters, there's a couple things that it could be related to. What might it indicate if they are shivering or have jitteriness? Yes, so like neonatal abstinence syndrome, that is one of them, definitely. So if they were exposed to drugs in utero, for example, usually it's going to be cocaine or opioids that cause these symptoms. Or, like Heather said, hypoglycemia. So those are the 2 big things that you see that can cause jitteriness. Your hypoglycemia and your neonatal abstinence or neonatal withdrawal can look very similar as far as the symptoms that you see with them. So if you check a blood sugar and your blood sugar's fine, might start thinking about, is baby withdrawing, which usually you're going to know babies have the potential to withdraw first, because they usually do a drug screen on the mothers. So if mom shows up positive for something, then you can start thinking about, is baby going to be having withdrawal symptoms. So hypoglycemia, I put for this one. Neonatal withdrawal is another cause. So what is a normal blood glucose in a term baby as well as in a preterm baby? A little bit lower. What's the minimum, I should say? Yeah, so it's pretty low, even down to 35 when we're talking about a preterm baby. So very, very low. They don't have much room to go if they start dropping their blood sugar. So that's why we harp on, if you have a macrosomic baby, for example, any baby who's at risk of dropping their blood sugars, that they're checking them frequently, because you want to catch that as soon as possible. Because once you get below 40 or 35 for preterm babies, that's when you start thinking about it can actually cause brain damage in those babies once they start going down that low, because they're not getting enough sugar. Your brain needs carbohydrates to function. So the other one that we just talked about, tremors or jitters, sneezing, yawning, increased irritability, diarrhea, anorexia, diaphoresis, all these can be related to that neonatal abstinence syndrome. So there are tons of symptoms we don't always think about as being related to neonatal abstinence, like the sneezing and yawning. People don't think about those, but those are associated with that as well. They'll also have impaired appetite, difficulty sleeping, this high-pitched, what we call a cat neuro cry. It sounds like a cat crying. It's very irritable, high-pitched, whiny type of cry. So these would be danger signs in a newborn that the parents should be taught if they're seen to contact their provider. So if parents see what symptoms in their baby, they need to seek medical attention. Yes, any symptoms of respiratory difficulty, so nasal flaring, if they're grunting, if they have retractions, if they have, yes, central cyanosis, so acrocyanosis, where it's just the hands and feet, is okay. But if they have central cyanosis, that is a problem. If they're difficult to arouse, if they're lethargic for more than an hour. So if you've ever tried to wake a baby that wants to sleep and you're trying to arouse them, you'll take their clothes off and kind of rub them, try and stimulate them. But if you're not able to really wake them up to feed for more than an hour. If they're floppy, yeah, if they're very just low tone, not really wanting to be interactive. If their temperature is low, if we always, or unstable as well. So we often think of infection with fevers, elevated temperatures. But something you'll see in children as well as in the geriatric population is temperature instability or even decreasing temperatures as opposed to elevated temperatures. Their hypothalamus knows something is wrong, but because it's immature, it can't quite figure out how to respond as far as adjusting the temperature. So sometimes instead of increasing the temperature, it will decrease their temperature. So a temp of 95 could be just as significant for an infection as a temp of 102. So temperature instability, refusing to feed, vomiting, and oftentimes when they're ill, they'll start out increased irritability and then progress into lethargy. When they progress into that lethargy, it's really concerning. All right. Asymmetrical gluteal fold, limited leg abduction, or one leg shorter than the other are all potentially symptoms of what? Yes, congenital hip dysplasia or hip dysplasia. So all these symptoms are associated with a hip that either the tendons and ligaments aren't strong enough, or more commonly that socket that the acetabulum fits in is shallow, so that the hip just kind of falls out easily. So when they are looking at some of those symptoms, assessment findings, if the gluteal folds are asymmetrical, if you can't abduct one of the legs, like you can't turn it out away from the body, if the Ortolani sign is positive, so we don't want a positive Ortolani sign. Ortolani's and Barlow's maneuver is where with Barlow, you're trying to dislocate that hip. And then when you do the Ortolani, where you're trying to push it back in, if you feel a click in the hip, what they call a hip click, then that is a sign of hip dysplasia. It's easy to treat, or relatively easy to treat. They put them in a Pavlik harness, Pavlik, for usually about 6 weeks or so, and most of the time that helps the situation. So congenital hip dysplasia, I just told you the treatment, that Pavlik harness. All right, this complication occurs due to inadequate reabsorption of CSF, or cerebrospinal fluid, into the ventricles. What can occur? Its literal translation is waterhead. As far as a more detailed analysis of this, we actually talk about more in pediatrics, but we just kind of mention it in the newborn book as far as recognizing the word. That is hydrocephalus. So hydrocephalus is where they have some kind of anatomical abnormality that causes that backup of that CSF. It's not reabsorbed properly. So oftentimes these children have to get a shunt to drain that fluid. But the super detailed information about hydrocephalus we cover more in pediatrics, just kind of recognizing what that is with newborn complications. All right, the best method to decrease perineal swelling and increase comfort in a new postpartum patient is to do what? What is the best method for swelling and comfort? Ice, cold packs, very good. We want to put some cold on her peri area to help with that swelling, and it will help with that comfort as well. She can continue to use it. After 24 hours, we can also incorporate warm sitz baths. So this is where they sit in a shallow amount of water and warm water, and this will help with soothing as well. But we don't want to do it within the first 24 hours because, one, it can actually increase bleeding because warmth opens up blood vessels, so you don't want to do that. But also on top of it, it can increase the risk of infection if they have open areas, like for example an episiotomy. So we want to wait 24 hours for those. But in the beginning, cold will help not only control bleeding but help with swelling and discomfort. All right. The newborn screening test. So the newborn screening test is where they do the blood test, and they put drops of blood on a card. And this card is sent off to the state lab, and they're testing for congenital genetic defects and metabolic defects. So they're looking for things like sickle cell anemia, cystic fibrosis, your metabolic defects like PKU, maple syrup urine disease, galactosemia, congenital hypothyroidism, not hypothyroidism that is acquired later on in life. You can get hypothyroidism that comes on later in life, but congenital hypothyroidism is where you are born with a either completely dysfunctional thyroid or sometimes even where it's missing. So with congenital hypothyroidism, they have to be started on Synthroid and stay on it, or whatever thyroid medication. Usually Synthroid is the most common one, levothyroxine, for the rest of their life. So this isn't like hypothyroid you develop later. So this is an example. There's like 22 that are tested for in Virginia. Every state, it's a requirement. It's by law requirement. And the reason they pick certain diseases to be on the newborn screening test is because these are diseases that are not going to be apparent at birth. You're not going to know just by looking at them that they have PKU or sickle cell anemia or something like that. But without treatment, it can develop some significant complications. So like PKU, they're not going to show any signs of intolerance of their formula or their breast milk, but then as they start developing that brain damage, that's when they'll have those symptoms, but by then it's too late. So this lets you know there's a problem with the baby before it gets to the point you have permanent irreversible damage. So a normal postpartum finding related to urination. What is normal and common and okay? As long as it's not associated with other symptoms, I should say. Increased urination, very good. That polyuria or that diuresis. Diuresis and diaphoresis are normal. It is just the mom's body getting rid of that extra fluid that she took on during pregnancy, and her body's now getting rid of it. So as long as there's not other symptoms associated with it, like fever or dysuria or other concerning symptoms, it's totally normal. Just keep on peeing. And then I mentioned what would be abnormal if they had dysuria or fever or other symptoms of infection. All right, swaddling, rocking, using a pacifier, creating a quiet environment. All these are things that we can use in an infant that are non-pharmacological pain management methods. So these are excellent examples of things we can do for baby to help soothe them and calm them. A lot of these you'll see used even with circumcisions. They'll use a pacifier, for example, with a sucrose solution. It's a solution that's sugar water. You put it on the pacifier and it's calming to them. So all these can be used for pain management and calming methods in babies. All right, what would be important to monitor is abnormal signs in the preterm infant. So there's several things that would be abnormal in the preterm infant. So a lot of it has to do with showing symptoms of instability. So they might have signs of respiratory distress, for example, where they're having the retractions or the grunting, signs of respiratory distress syndrome, any kind of signs of infection like that lethargy, irritability, fever, refusing to feed, or on the other side if they're having vomiting. If they're having skin color changes like pallor, if they're pale or they're blue, that is definitely a big problem. Bulging fontanelles, so their fontanelles should be flat. When you rub your hand across baby's head, it should just feel kind of level. It shouldn't feel sunken where you can actually see the edges of the skull bones or feel them, and it shouldn't be bulged up. So bulging fontanelles indicates there's some kind of fluid accumulation in the head. Could be from a head injury, for example, or could be that hydrocephalus we just mentioned. All right, normal uterine involution process. So we talked a little bit about this already on one of the other questions in the other portion. So normal uterine involution, the uterus should be midline and firm, and it should be at the umbilicus or a centimeter above right after birth. And then it's going to descend 1 to 2 centimeters every 12 to 24 hours. So within 12 hours, it might be right at the umbilicus, and then slowly descend beyond that. Usually by 10 to 14 days postpartum, you can no longer feel the fundus at all. So it goes away relatively quickly as far as where it descends back behind that pubic bone. So when we're talking about involution, that is the return back to that pre-pregnancy status. The most important assessment in an infant with macrosomia. What is the most important thing we are checking in a baby with macrosomia? Yes, glucose. That is absolutely most important, especially in that first 24 hours after a baby is born. They have a high risk of dropping their glucose, and we've already talked about what normal blood glucose is for these patients, so they don't have very far to fall. So we want to catch it as soon as possible and get them some kind of treatment for it. They may try an oral glucose solution first, but really you're not going to get on top of managing that hypoglycemia till they can get something with some kind of nutritional support, like breast milk or formula. They need the protein to help kind of stabilize those blood glucoses. So sugar will make it rise, and it'll make it rise pretty rapidly, but they're going to crash. And that's how you get roller coasters in diabetic patients. When diabetic patients drop their blood sugar, they'll eat something that's just sugar or drink something that's just sugar, so they rise up, and then once it wears out, they crash again. So it's just up and down until you can get something with protein in them, in this case with newborns, formula or breast milk. So they'll start with like sugar water or something, but then they're going to be working towards giving them something more substantial. All right, a good therapeutic communication technique for a patient who had an unexpected outcome. So when you have a patient who has an unexpected outcome, NCLEX likes to use the therapeutic technique of acknowledging their feelings and offering help, being present. So presence is another important one. So not blowing off how they're feeling. If they're sad about something, you're not going to say, well, it was for the best. You're going to acknowledge how they're feeling. And also help them, whether it be to sit with them or whether it be to get them counseling or whatever it be. Those are two big NCLEX therapeutic communication techniques. All right. Normal newborn weight loss. We already talked about this one, so I won't harp on this one, but 5 to 10%, we talked about that with that weight loss calculation. So 5 to 10%, and they should come back to their birth weight within 10 days, normally for a term baby. Preterm babies, because it can be harder for them to come back to their birth weight, they may give them 14 days depending on the situation, but generally most term babies are going to be 10 days. Five to 10% in 10 days. Normal newborn alterations regarding the reproductive system, specifically in the female baby. So there's two things you see in the female baby that are totally normal, but could be alarming to mom. What might they be? With the reproductive system. Yeah, they're blue, definitely. Yes, so vaginal discharge is one. So they will have something we call pseudomenstruation. So they can have some bloody vaginal discharge from their vagina. And it's normal. It's just related to the estrogen from mom. But for a parent that sees their baby girl having vaginal discharge that's bloody, it can be quite alarming. So making sure that they're aware that can happen. They do have enlarged labias. And the other one that you see is breast discharge. So they will have a white milky discharge from their breasts. You'll hear it called in layman's terms witch's milk. It is, again, normal. It's those hormonal effects from mom. It's not concerning. It will stop on its own. So vaginal discharge and breast discharge, totally normal in your baby girl patients. All right. Normal skin variations in newborns. So there's several different types of normal skin variations that you'll see that are not concerning. They're oftentimes things that you won't treat. What are some of them that you see? Yeah, they'll have the like the lanugo. Yeah, especially in preterm babies, you'll see more of that lanugo covering. The later they go on, like your post-term babies, for example, often that lanugo starts to disappear more and more. But especially if they are preterm babies, you'll see a significant amount of it. Port wine stains, yes. The problem with port wine stains is they will often watch those to make sure they don't turn into a problem. Port wine stains can be very large. If you've never seen one, they are very dark. A lot of times they're usually like a red wine color, and that's why they call them port wine stains. And they can impede blood flow if they get but so large. They have a very clearly demarcated area. So when I mean by demarcated, it's a very clear line of where the end of the birthmark ends. Yeah, and you can see them anywhere on their body. Sometimes they are not concerning, and they'll just watch it and make sure, kind of like hemangiomas. Hemangiomas can get very large as well, and they can be concerning. But for the most part, most port wine stains, most birthmarks don't become concerning because they don't turn into anything, but sometimes they'll watch them just to make sure they don't get overly large. Kind of going with the port wine stains, you get something called nevi, which is just birthmarks. So one example, telangiectatic nevi, which you'll hear people called stork bites. So they'll have these little reddish marks sometimes on their face or on their neck. They usually go away with time. Some of the other ones that you see will be the Mongolian spots. So typically Mongolian spots are seen in your African American and your Hispanic American patients. And it's usually seen on the backside or the buttocks, and they're like a purplish blue color. It's just a birthmark. They don't mean anything. They never go away. They usually lighten up significantly as the child gets older, and unless you're really looking for it, they might not be noticeable, but they never completely go away. Yes, I've seen them in a few Asians as well. So they're fine. The only thing is making sure that, you know, parents are aware it's not abuse related, because when you first see it, it can look kind of like bruising, but it is not. It is just a birthmark. Another thing that you'll see in babies that has nothing to do with their racial background or their culture is milia, and they're these little white dots that you'll see on usually on their face, and they are keratin cysts. They go away on their own. They're not concerning. Exactly. A lot of people call them milk bumps. But they're fine. They will go away on their own. Another thing that you might see is called erythema toxicum, and this is where they'll get like the macules and papules on their chest or abdomen most commonly, and you'll hear that called baby acne. It sounds terrible. The name of it sounds terrible, but it's not. The biggest thing with like the milia and the erythema toxicum is making sure that parents are aware. Don't pick at it. Don't try to open it up or anything like that, because it can cause scarring and infection just like acne would. So making sure that they're aware of that. So that's some of the newer ones we talked about. Milia, Mongolian, so nevi, which is a term just as a general your different types of birthmarks. So some of the abnormal stuff, if they have jaundice, especially if they have pathological jaundice, where the onset is less than 4 hours or less than 24 hours after birth. Petechia is never normal. So petechia, where they have the little reddish or purplish spots, indicates some kind of bleeding difficulty. And then another thing that's abnormal is something called a hemangioma. It's a lot of times raised, and the reason is, I mentioned already with the hemangiomas, they can get rather large. And they can actually impede blood flow, so they'll keep an eye on it to make sure it doesn't cause any complications. But sometimes they do just fine, and there's nothing you even need to do about it, but it's definitely something that they'll watch for to make sure. All right, the 2 best methods for determining understanding when patient education is performed. So what are you going to do? You educate your patient, and then you're going to do what to make sure they understand? Yep, teach back. What's the other one? So we can do teach back, where we have the patient, hey, tell me 3 things you learned about our conversation. And then the other one, return demonstration. So show me, yeah, exactly, demonstrate. Show me how to do your blood sugar, for example. So when you're having patients, when you're teaching patients, if they just say, I understand, or they shake their head or things like that, especially when you have patients from other cultures, sometimes in their culture, they're not going to be willing to speak up and say, I don't understand, or I have a language barrier, or whatever it is. So they may agree, not because they actually understand, but because they don't want to be a bother, which of course they're not. But just because they shake their head or say they understand doesn't mean that they do. So making sure that if they can teach it back to us or show us what they need to do, then we know if they understood it, and we can clarify anything that was misunderstood. So primary nursing intervention, if you have a baby who has apnea, so it's normal for infants to have periods of apnea up to 15 seconds. It's very common. They have very irregular breathing as infants, so they'll have periods of apnea interspersed with panting. But if they have a longer period of apnea, what's something we can do to get them going, hopefully? So it's not like in the movies where you see where they smack babies on the bottom to get them to cry. They don't do that anymore. We stimulate them and hopefully get them to breathe and get them to cry. Usually the way we do it nowadays is we'll rub or pat the bottom of their feet, and that will, or take their clothes off if you expose them to the air. The cold air sometimes will kind of shock them into waking up, but we stimulate them either with rubbing or patting their feet, taking their clothes off, something like that. But we want to stimulate them first because sometimes they just need a little extra reminder to breathe, especially preterm babies. They forget to breathe very easily. All right, the primary nursing intervention, if you have an IV infusion complication, so you're giving an intravenous medication and they start having a reaction, what's the first thing you do? Stop the infusion. Very easy. If you have a problem, you take away the problem. Y'all usually know that one. All right, last one. Symptoms of respiratory distress in an infant, which we actually talked about this. We talked about several of them. So what are some of the things we talked about as symptoms of respiratory distress in an infant? Yes, nasal flaring, retractions. They may have tachypnea, where they're breathing fast. They may have the, what's the word I'm looking for? Grunting. That's the word I was looking for. Grunting. So those are all symptoms, and some of those we will see in adults. Like adults, you may see retractions, especially if it's severe, or tachypnea, but grunting and nasal flaring aren't typically things you see in adults, so that's a little bit different as far as pediatrics. All right, ladies, thank you for joining me. Do y'all have any questions for me I can answer? I'm so glad. I'm glad it was helpful. And luckily, we were able to do it virtually because I know some of you don't always get to join when we do it on campus. So that's great. And of course, I did record this, so I have to compile it before I can load it up onto YouTube. So I'll have it by tomorrow. It should work, and I'll get it on there so you'll be able to go back and watch it again. And not to mention, there is another one from a couple semesters ago that kind of covers similar content. So there's a couple videos on there. Y'all are very welcome, and some of you I will see next week, but the rest of you I will see you in about an hour. So y'all go get something to eat or whatever it be and come on back. Well, actually not here. I'll see you on Collaborate, but I'll see you in a little bit. For those of you that are done, what's that?
The Kahoot. Where can I find that as well?
I will open that up after I play it in class tonight. So it's not open right now. I have it blocked until I do it in class, but after tonight I'll open that up so you'll be able to see it.
Okay, and will the link be posted like in the announcements or something?
You can just use my username, the PedsRN teacher, to find it.
PedsRN. Okay. If I can't find it, I'll email you.
Okay.
Okay, thank you.
Oh, you're welcome. Yeah, I have it locked right now until we get done with all my classes, and then I'll open it up after that. Yo, stay safe too. If y'all got to go out, please be careful. And I will see y'all next week.